Today's topic is pneumothorax. Can anybody tell me what do you mean by pneumo? Can anybody say me what do you mean by pneumo in Latin? Pneumo means and thorax means hello. Okay, so pneumo means ear and thorax means chest. It means there is a ear inside the chest, inside the thoracic cavity. Just a minute here. Okay. So there is a ear inside the thoracic cavity. Usually it's accumulated in between visceral and skeletal pleura. There are in between the space here. Okay. There are so many causes that ear may enter inside the thoracic cavity. It might be a spontaneous, it might be a secondary cause. If it is a spontaneous cause, if it is without any causes, we cannot find the cause, then that is called primary. It's without etiology. And if it is due to some other reason or some other comorbidities or some other diseases, and this is called secondary pneumothorax. So usually primary pneumothorax is very rare. It's often with those who are smoker and tall male, who do have small blebs in the lungs. Usually they located in the apical region of the lungs, and normal chest X-ray may not detect these blebs here, and then we may go for CT scan of the chest. This is primary, and this is usually it might be asymptomatic if it is very small and it resolves itself. And secondary is a life-threatening condition. So it's depend on the size of the pneumothorax. If the pneumothorax is large, then it would compromise the space in between the thoracic cavity. It might push another lung also. So, and there might be a huge collapse of the lungs collapse, and then the patient may develop severe pain and shortness of breath. And we may lose patient with hypoxic damage, with hypoxia and other causes. So let's go further here. The first Itard in 1803, he explained about the pneumothorax here, and then I told you before also there's a spontaneous and traumatic. Spontaneous may be a primary, it's a pneumothorax, simple pneumothorax, and secondary traumatic may be a iatrogenic and non-iatrogenic. So iatrogenic means it's due to some medical procedure or due to some medical personnel, and non-iatrogenic means it's a blunt trauma or external trauma and other things. Usually in iatrogenic, when you do some instrumentation or something inside the lungs or inside the thoracic cavity, in such a condition, air may enter into the thoracic cavity, and it might be a closed pneumothorax. Usually it might be a very small, or sometimes it might be a very big pneumothorax. So you may need chest tube drainage or suction of the air in different clinical conditions here. In iatrogenic, usually if you go for this is a central venous catheterization, or if you go for pleural fluid tapping, or if you go for intubation and other things, then there might be a pneumothorax. So it's pneumothorax due to some medical instrumentation that is called iatrogenic. Non-iatrogenic may be a traumatic, only a traumatic. It might be a blunt or open trauma. So if it is open with the air space, then we call it open trauma, open pneumothorax. And if it is not connected with the open space, then it is a closed pneumothorax. And if it is a closed pneumothorax, it's closed everything, then it's a closed pneumothorax. It's not increased in size. But if there is a valve like a structure which allow the air to go one way to the pneumothoracic space in the inspiration, then it may increase the size of the air space may increase in every breathing, and that is called tension pneumothorax. That's a very difficult situation. Then again, pneumo means air and thorax means chest here. I told you before also. Defined as the presence of the air or the gas in the pleural cavity, that is the potential space between the visceral and the parietal flora of the lungs here. Clinical results are dependent on the degree of the collapse of the lungs on affected sites. Usually lungs is collapsed in pneumothorax on the affected sites. If it is large, then there is a huge collapse of the lungs, and there might be a decompensation of the oxygenation, and the patient may develop hypoxic damage, and then patient sinus, and then patient may need intubation if we do not properly do something in the on time, then we may lose the patient. Can impair the oxygenation or the ventilation here. It is significant. It can cause a shift of the mediastinum and compromise the hemodynamic stability. Usually the first sign of the pneumothorax or the cyanosis but the first sign of the air in the space sometimes may be a tachycardia only. The first is tachycardia. Later on, the decreasing of the blood pressure is a low blood pressure. So then hypotension and the tachycardia may be the first sign there, and tachypnea, of course. Then air can enter in the intrapleural space through the communication from the chest wall, that is trauma, or through the lungs parenchyma across the visceral pleura. So this is a pneumothorax. Then primary spontaneous pneumothorax. Primary, it is, I told you, it is occurs in people without underlying lungs disease. There is no etiology. We cannot say why there is a pneumothorax. And in the absence of an inciting events or the factors. In other words, air enter into the intrapleural space without preceding trauma or without any underlying history of the clinical lungs disease. However, many patients whose condition is labeled as the primary spontaneous pneumothorax have subclinical lungs disease such as pleural blephs, and these blephs are very small, maybe a very small that may not be detected by the X-ray. So we may go for CT chest. Yes, patients are typically aged in between 18 to 40 years. They are tall, thin, and often they are smokers. Secondary pneumothorax, spontaneous pneumothorax, occurs in the people with a wide variety of parenchymal disease. It's like a COPD, or it's like some abnormalities of the lungs structure. Air enter the pleural space via distended, damaged, or the compromised alveoli. The presentation of this patient may include more seriously clinical symptoms and sequelae due to the comorbid condition. But this secondary pneumothorax, we should treat them, we should admit them, because the cause of the pneumothorax is there. Still, you are not treating the cause of the secondary pneumothorax. In primary, if the blephs is very small, if it ruptured there, so the pneumothorax may be a very small. Sometimes this type of patient may be, they may not have some clinical conditions, clinical symptoms here. They are asymptomatic, and sometimes maybe they are mildly symptomatic, and you can treat on the basis of OPD basis. It means you can treat the patient and send home in primary pneumothorax if it is a small. In secondary pneumothorax, please remember that you should admit the patient to avoid further complications. Yes, iatrogenic, it is due to some clinical instrumentation. It is traumatic pneumothorax that results from the injury to the pleura, with the air induced into the pleural space secondary to the diagnostic or therapeutic medical interventions. Then, half of the century ago, this 50 years back, iatrogenic pneumothorax was predominantly of the result of the deliberate injection of air into the pleural space for the treatment of the tuberculosis. So it is first they used to insert the drugs into the pleural space there. The terminology evolved to the prefer of the induced or the artificial pneumothorax to indicate the pulmonary tuberculosis treatment before arriving at the current classification. Pulmonary tuberculosis remains the significant cause of the secondary pneumothorax now. Non-iatrogenic or the traumatic pneumothorax is not due to some medical intervention. It's a spontaneous, or it's a traumatic, or due to the trauma. So then, for this result from the blunt trauma or the penetrating trauma, open trauma, and that disturb the parietal and the visceral pleura. So management steps for the traumatic pneumothorax are similar to those for other non-traumatic cause. If the hemodynamic and the respiratory status is compromised of an open, it's communicating to the atmosphere and the or hemothorax. Usually, if there's a trauma, it is presented with hemothorax and the pneumothorax. It means there is a half blood and half air. So are also present tube. Then we may insert the tube. Thoracostomy tube is performed to evacuate air and allow re-expansion of the lungs here. There is a subset of the traumatic pneumothorax classified as the occult. That is, they cannot be seen on chest radiograph, but can be seen in CT scan if it is very small pneumothorax. In general, this can be observed and treated if they are become symptomatic here. If the pneumothorax is more than 2 centimeters, the rim of the pneumothorax is more than 2 centimeters, this type of patient may need immediate medical management. And if the rim in the X-ray, if the rim of the pneumothorax is more than 2 centimeters, rim of the ear is more than 2 centimeters in X-ray, then this type of patient immediate to admit in the hospital, immediate to go for either suction of the ear or insert the tube, chest tube here. Okay, so in 2002, the 2002 consensus, it classified the pneumothorax in small pneumothorax and big pneumothorax, and the landmark is 2 centimeters. If it is less than the rim of the X-ray, the rim of the ear is less than 2 centimeters. These are known as the small pneumothorax. This type of patient may not be admitted. And if the rim of the X-ray, the rim of the ear is more than 2 centimeters, then they should be admitted. They're known as a large pneumothorax. So closed pneumothorax communication between lungs and the pleural space seals off. It means the ear goes into the pleural space and it's sealed off. It means there is no way to go inside into the pleural space. Okay, so there's a ear. There's a definite amount of the ear. Means pleural pressure remains the negative and infection is usually uncommon. So you open pneumothorax is communicate fails to seal the ear, continues to transfer freely between the lungs and the pleural space here, and can also facilitate the transmission of the infection. They usually develop infection, either pneumonitis or the pneumonia. For example, bronchopleural fistula following the rupture of an emphysematous bulla, tubercular cavity, or the lungs abscess into the pleural cavity. So in this condition, the ear may freely goes into the pleural space and come back to the bronchial space. So in this condition, patient may develop infection here in open pneumothorax. Tension pneumothorax, this is one of the most devastating situations. It's one of the most dangerous pneumothorax. Here, there is a valve, one-way valve, goes into the pleural space, ear into the pleural space, and when the patient expirate, it means not inspirate, expirate, the valve is closed, and when patient inspirate, the valve is open there. It means the negative pressure inside the pleural cavity will develop very fast, and the size of the pneumothorax will increase very fast in your eyes if you have a patient, and then patient may deteriorate very rapidly, and sometimes you may lose the patient. So communication between the pleura and the lungs persist as in one-way valve here. Then interpleural pressure above atmospheric level here, mediastinal displacement and compression of the opposite lung and the cardiovascular compromise, rapidly progressing breathlessness, marked tachycardia, hypotension, and the cyanosis occurs during the mechanical ventilation or resuscitative effort in CPR. Difficulty in ventilation during the resuscitation or high peak inspiration pressure during the mechanical ventilation strongly suggested the diagnosis medical emergency. So this ventilation, the question is here with the ventilation, mechanical ventilation. There are two parameters in mechanical ventilation usually to develop the tension pneumothorax. One is the air volume that you are giving per minute, yes, that we call it the tidal volume. Another one is PEP, that's the pressure to the lungs. So if you keep the high peak inspiration pressure is a high PEP, then, or if you keep the high tidal volume, then patient may develop tension pneumothorax here. So in such a condition, if you suspect the tension pneumothorax, you should immediate make it open pneumothorax. It means you should immediate give some space to air to come out from the closed space. Okay, so to decrease the pressure, pleural pressure. Okay. Then in inspiration, here you see here the air goes inside, and in expiration it's sealed over here, so air cannot come out, and they develop what? They develop here the tension pneumothorax, and it increase the pneumothorax increase in your eyes, increase in your eyes. Patient may deteriorate, patient may have a tachycardia, marked tachycardia, or hypotension. You can feel, or you can see here in the emergencies here. So in again in inspiration, so it goes here inside the ear. Here this is a valve here, one-way valve you see. Then in aspiration, this valve here closed and it cannot go out. So then in every inspiration, the size of the pneumothorax will increase here. Then this is called tension pneumothorax. Incident male more than female here usually is usually if you see the primary pneumothorax, then it's commonly in between 15 to 30 years, and if it is secondary, it's commonly between above 60 years. You cannot imagine smoking versus non-smoking. So smokers has a chance of pneumothorax 120 times larger, more than non-smoker. So smoking, they may have up to 12% and versus 0.1%. So it means if one non-smoker will have a pneumothorax, and there will be 120 people, other smokers have a pneumothorax. So then presence of the apical subpleural blebs and the bulla. So it's patient is thin, high, tall, and usually from 18 to 40 years, and they do have a blebs, and they might rupture there, and they develop the spontaneous primary pneumothorax. Secondary pneumothorax most common in old age, those living in urban, pulmonary fibrosis, emphysema, and other things. Causes traumatic or iatrogenic is a penetrating word. Iatrogenic usually transthoracic needle aspiration. So 1/4 of the population, when you go for the needle aspiration, transthoracic, so 1/4 of those population may develop pneumothorax here. Another one is IC nerve block here, intercostal nerve block. Pleural biopsy up to 8%, lungs biopsy, subclavian vessels puncture. This is another one very commonly we used to see, one in fifth or one in fourth patient. So then chest compression injury, including the external cardiac massage when you are doing CPR. So you may develop pneumothorax, and mechanical ventilation, so up to 7%. But in mechanical ventilation, please remember that it's dependent on the tidal volume and the PEP pressure that you are giving inside the lungs. And then usually they are tension pneumothorax. Spontaneous primary, this I already told, that's a tall asthenic, asthenic is a young smoker. Rupture of the subpleural apical blebs, probably congenital here. Secondary is a chronic bronchitis, emphysema, rupture of the subpleural blebs, emphysematous bullae or pleural blebs. Then other things here, asthma or congenital cyst bullae, cystic fibrosis, these are secondary here, okay, with lung disease here. Then clinical manifestation, most episodes of the primary spontaneous pneumothorax occur at rest. It means, so there should be no any trauma, there should be no any other causes, and these are primary spontaneous pneumothorax, and it usually occurs at rest. Sudden onset of unilateral chest pain, breathlessness. Symptoms of secondary pneumothorax are more severe than the primary here. Patient with small pneumothorax, it's a physical examination may be normal except tachycardia. Please remember that tachycardia may be a single or the first sign of the pneumothorax. So then large pneumothorax is covered, if it is covered more than 15% of the hemithorax, so single lungs, then that is a large pneumothorax. Decreased movement of the chest wall, it's a mediastinal shift. Intercostal bulging, the most important, you can see these things here, and hyperresonant percussion note, and decreased or the absence breath sounds on auscultation. So these are some other clinical conditions that you may have pneumothorax with your patient. The most important is hyperresonant percussion sound note, or decrease or the absence of the breath sound. So usually if it is tension pneumothorax, or usually if it is a big pneumothorax, there might be no breath sound here. There might be no breath sound. The size in 1993, the small rim of the ear around the long moderate is a collapse halfway towards the heart border, and complete is earless lungs is separate from the diaphragm. And now in 2003, I told you before also, if it is a small pneumothorax, we call it the rim of the air space in the X-ray, maybe a less than 2 centimeter, large is more than 2 centimeter. So small and large here. So this is a pneumothorax. It's a collapsed lungs. You see here. You see here. It's normal here. It's a normal lungs here on your right side. On the left side, if you see the left side here, this is a pneumothorax here. This is a pneumothorax. Okay, collapsed lung. So then management. The first is oxygen. Your oxygen. So you might need a high flow of the oxygen. So if it is small, you might need a small flow, less low flow of the oxygen here, oxygen volume. If you cannot, if your patient is not okay with the oxygen, patient is still unrest, or patient is still tachypneic or cynosed, then the most important, if the patient has a large pneumothorax, either closed pneumothorax or the tension pneumothorax, then the first line for the treatment requiring the intervention is subcutaneous needle aspiration. So give a needle and aspirate the ear. Less likely to succeed the secondary pneumothorax. In secondary pneumothorax, you should go for other things. In primary, it means there is no source further to accumulate the ear. And if you suck the ear that inside the trachea space, then patient may not have maybe a good with these only, because there is no source of the ear further inside the so pneumothorax. So you may not go for the to treat the cause here. But in secondary, you should treat the cause before you go for other things here. In secondary, you should treat the cause here. Intercostal tube drainage, the most important, the most frequent that we do here. Chest drain suction here, pleurodesis, if the pneumothorax persists for a long time and you cannot close the space there where the air is leaked, then we may go for the pleurodesis. Surgical treatment, thoracotomy or lobectomy or the removal of the lungs here. So then this surgical treatment may need here. You once should stop the smoking, and if the patient with the pneumothorax, so don't allow them to fly or the driving here. Yes, it might further deteriorate their oxygenation in patient may develop further cyanosis. And then if one has a pneumothorax, then please ask them to see further in even after discharge, they might have a further attack of the pneumothorax here. So if the primary pneumothorax, again, breathlessness and rim of the ear is less than 2 centimeter, yes, no, not more than 2 centimeter, no breathlessness, nothing, though you consider discharge them. Yes, they are breathlessness, the rim of the ear is more than 2 centimeter, aspirate. If you successfully aspirate, patient is okay. It's a primary, I'm telling you, it's not a secondary. One, you may not need to treat the cause. In primary, if you aspirate successfully, patient is okay, then you may discharge the patient here. If you aspirate successfully, no, then you may go for the intercostal drainage. If it is successfully, then remove after 24 hours, fully expansion of the lungs. There is nothing further, then you may consider the discharge. If it is not, even after 24 hours, and even intercostal drain may not help them, then please refer them to the chest physician or the chest the thoracic surgeon. If it is prolonged for more than 5 days here, they may need a surgical intervention if they do have a more than 5 days. So in secondary, then in secondary, uh, breathlessness, patient is more than 50 years, ear of rim is more than 2 centimeter on chest X-ray. If it is not here, then aspirate successfully, admit to the hospital for 24 hours. Nothing is there, so patient is comfortable for 24 hours, then consider discharge here. So you please remember that in all secondary pneumothorax, you go for the admission here. Okay. If the patient is breathless, patient is more than 50 years, the rim of ear is more than 2 centimeter on X-ray, you please go for intercostal drain, successfully drain it, yes, then remove after 24 hours full expansion or cessation of the air leak here, then nothing after, even after 24 hours after removing this chest tube, if the patient is okay, you can consider them. No, you cannot. Intercostal drain may not help them. Immediately refer to the physician after 48 hours. Maybe you may need a suction or successful suction. If yes, then again you remove the suction or the chest tube. Again consider for discharge. If not, order decision with the surgeon after 3 days. If the patient is sinus for the 3 days, if patient is in primary, you may send the patient after 5 days. Here in secondary, you should send the patient to the surgeon after 3 days. Or sometimes, if depend on the clinical condition, if the patient is, if it is a secondary pneumothorax, if the patient is clinically very ill, oxygenation is not there with the high flow of the oxygen and your intercostal drain or the suction is not working, then you should immediately refer patient to the surgeon to immediate intervent for this secondary pneumothorax. Indication for the intercostal tube drainage here. It's a tension pneumothorax, number one. Symptomatic patient associated with the underlying pathology is a secondary pneumothorax with a symptomatic patient here. Yes, hydropneumothorax, when there is a half of pleura space is filled with liquid or fluid, and the half is with air, then this is a hydropneumothorax. So in this condition, radiologically volume of the pneumothorax is more than 1/3 of the pneumothorax. Then if no improvement after 7 days of the observation in the hospital, then we may go for the IC tube, it's the intercostal tube drainage. Then removal of the intercostal tube drainage, please remember that if it is, you please, you see there is a tube and there is a water seal bag, and that tube is inserted into the water seal bag to avoid the air goes into the pleural space. So if there is a bubbles in the bubbles inside the water in the inspiration, it means there is still air inside the pleural space. So that tube should continue. Okay, there is no bubbles for 24 hours. Then you can clamp the tube for 12 to 24 hours. You have an X-ray. In X-ray, there is no pneumothorax. Please remove the tube, IC tube. Keep the patient for the next 24 hours. Again, have an X-ray after 24 hours. And there is nothing, then you may send the patient. If there is when you clamp the tube, there is a air or the pneumothorax is increased, then you please release the tube here. If you remove the tube, again there is an accumulation of the air inside the pleural space, then you should again reinsert the tube. Okay, this is how to remove the tube. Removal of the IC tube is very important because it might further damage or further harm the patient if you do not take it in proper way. The first is there should be no bubble air through the underwater seal drainage for 24 hours. Get an X-ray, it's okay. Clamp the tube. Again get an X-ray for after 24 hours or 12 hours. It's almost normal. Then remove the tube. Okay. For discharge, again get an X-ray after 1 day. Everything is okay. Then you can discharge the patient here. Complication of the IC tube drain here, intercostal tube drainage. When you insert the intercostal tube for the pneumothorax here, you may penetrate the major organs. You may develop the emphysema, surgical emphysema, failure of the resolution, aberrant tube placement, and re-expansion pulmonary edema, RPO. So this is another condition when we may harm the patient here. If there's a huge pneumothorax or tension pneumothorax, if you release it very fast, then there is a very fast expansion of the lungs tissue, and there is a negative pressure inside the lungs tissue and the positive pressure outside. And always you please remember that water travel from the fluid travel from the high pressure to the low pressure. Then this expand pulmonary tissues, they may develop pulmonary edema, and that is called re-expansile pulmonary edema. So if it is in tension pneumothorax or large pneumothorax, please remember that you should release it very slowly. Surgery, bilateral spontaneous pneumothorax here, secondary epilepsy pneumothorax, first contralateral pneumothorax, persistent leak, 5 to 7 days, tube drainage, ear leak, or failure to completely re-expand, spontaneous pneumothorax, or personal risk act pilot or the drivers. So in these conditions, you may send the patient to the surgery and they may seal or they may remove the lungs. Pneumothorax in the ears, there are about 1% of the HIV AIDS, they may develop the pneumothorax. 2 to 5% of the AIDS will develop the pneumothorax of the PCP here. Then there is a refractory nature of the ear leak, high incidence of bilateral and high incidence of recurrent pneumothorax, and steroid may increase the risk of the morbidity from the AIDS-related pneumothorax. Audit tube drainage and periodontitis and surgery may help to those type of patient. So if the patient with AIDS, HIV/AIDS, there are people who are living with HIV/AIDS, they may develop pneumothorax. 1/4 of those population may develop pneumothorax, up to 25%. In the summary, small and the large pneumothorax, presence of the visible rim of the ear less than 2 centimeters, more than 2 centimeters between the lungs margin and the chest wall here. Observation, the treatment of the choice for the small closed pneumothorax without breathlessness, and breathlessness patients should not be left without intervention regardless the size of the pneumothorax. Please here you remember here, this is very important point. Sometimes you may have a rotated X-rays. Sometimes you may not have a real volume of the, you cannot calculate the real volume of the ear inside the space in the X-rays. So if the patient is dyspneic in spite of having a small pneumothorax, then you should not left patient without intervention. And simple aspiration, the first line of the treatment for all primary pneumothorax, not secondary, primary pneumothorax. And then intercostal tube drainage is recommended in secondary pneumothorax, except the patient with less than 1 centimeter size, which who are not breathlessness. A bulbing chest tube should never be clamped. You can clamp the bulbing chest tube here. Chemical periodontitis should only be attempted if the patient is unable to go for the surgery. In case of present ear leak or failure of lungs to expand, seek an early 3 to 5 days thoracic surgical opinion further. Okay, this is all for pneumothorax. Do you have any question? Are you listening me?
Yes, sir.